Hello, everyone. Thank you for joining us. Today's cancer virtual seminar topic is Orthopedic Oncology 101. My name is Carmen Boone. I'm an outreach coordinator for the Samaritan Cancer Resource Center, and I'll be your host and moderator. This event is brought to you by the Samaritan Cancer Resource Center. We partner with anyone touched by cancer to provide the support they need to live with strength, determination, and hope into the future. Joining us today is Dr. Nicholas Tedesco. He's with Samaritan Health Services. He's an orthopedic surgeon who specializes in orthopedic oncology and joint reconstruction. He became interested in medicine because he was fascinated with health, human anatomy, and physiology. He's passionate about preventative health and improving both the quality and quantity of people's lives. He chose to practice as a Samaritan because he wanted to offer orthopedic oncology in the Willamette Valley. Dr. Tedesco also actively teaches resident physicians and medical students and is currently an associate program director for the Orthopedic Surgery Residency Program. He enjoys woodworking, baseball, exercising, being in the great outdoors, and spending time with family. And thank you so much for being here with us, Dr. Tedesco. I will go ahead and pass the presentation over to you.
All right, thank you. Well, yes, I am Nicholas Tedesco. I am an orthopedic oncologist, and I specialize in that and complex joint reconstruction, which is sort of an offshoot of that. And so a lot of people don't know what orthopedic oncology is, a lot of physicians included, and so I'll talk about that today. I'll also talk about what we specialize in, specifically the type of cancer, is something called sarcoma, and what that is, what that means, and what we're doing for it here in Corvallis. So what we're going to go over today is what exactly is sarcoma and what are we doing here to help treat it, as well as help internationally learn about these disorders. And then what exactly is orthopedic oncology, what's its history, and what is limb salvage surgery, and where do I come in the whole treatment paradigm for this particular disease. So sarcoma, the term literally translates to flesh mass. There are two main types of cancer whenever we look at all cancers, and that's sarcoma and carcinoma. These are named for their origin of tissue. So sarcoma comes from the connective tissue and blood vessels in our body, basically anything that doesn't have a connection with the outside world. And carcinoma comes from the linings of our body, or things that ultimately communicate either directly, like the skin, or indirectly, like sweat glands or the kidneys, because they go through the ureters, into the bladder, and into the urethra and out the body. So they are indirectly ultimately connected to the outside world, but our connective tissue and blood vessels are not. And so sarcoma is a very specific type of cancer, and it's very rare. There are about 65 different subtypes of sarcoma, but all 65 of these collectively make up less than 1% of all cancers. In fact, of all of these 65 subtypes, less than 15,000 total cases per year are diagnosed in the United States. So these are very rare, whereas carcinoma is all the common things that we know about: breast cancer, prostate cancer, colon cancer, kidney cancer, bladder cancer, skin cancer. So when it comes to sarcoma, not a whole lot is known because not a whole lot of cases are out there to study very well. There are two main types of sarcoma: bone and soft tissue. So bone sarcomas are those that arise directly inside the bone to start with. They can spread anywhere else in the body, which is the definition of cancer, whereas benign tumors stay only local where they start and never spread anywhere else. But if it started in the bone, it's called a bone sarcoma. The three main subtypes of bone sarcoma are osteosarcoma, Ewing sarcoma, and chondrosarcoma. Osteosarcoma and Ewing sarcoma are much more common in children, but chondrosarcoma is much more common in adults. Soft tissue sarcoma includes connective tissue sarcomas. So leiomyosarcoma and liposarcoma come from basically the smooth muscle cells in our body, which are the muscle cells that we don't actively control, like in the uterus or the bowel or around blood vessels. And liposarcoma comes from fat, basically either underneath the skin or the fat that we have protecting and insulating our deeper structures. Common blood vessel sarcomas include angiosarcoma, with angio meaning blood vessel. These involve both adults and children, with some of the variants being much more common in children and some of the variants being much more common in adults. These can be challenging cases to manage because they're rare and because these usually actually don't respond to the conventional methods that we often use when we treat the more common carcinomas like breast cancer or prostate cancer. Because sarcoma is so rare and it's so specialized of a spectrum of diseases, historically people would have to travel very long distances to find a sarcoma specialist. I've been servicing the southern half of Oregon since 2016, and I'm one of only 5 orthopedic oncologists in the state and the only one outside of Portland. So I'm it between Portland and Sacramento. There's only about 125 of us nationwide. So we're very few and far between because these things are so rare. Here at Good Samaritan, what we're doing is, number one, we're now treating these diseases and you no longer have to travel to California, Seattle, or Portland to get them managed. But we're also participating on a national level. So we're currently involved with multi-institutional studies with the Medical University of South Carolina, UC Davis, and Allegheny in Pittsburgh regarding sarcoma management. We're also in collaborations with the University of Chicago, OHSU, and Georgetown University on studies that we're starting here. We also run a local database and case repository of all of our sarcomas, and we plan to start uploading that and contributing this year to a national sarcoma database, which is the first of its kind that's being developed by the Musculoskeletal Tumor Society. I serve on the evidence-based medicine committee nationally with the Musculoskeletal Tumor Society and was actually involved with the very early discussions with this national sarcoma database. And I'm on the board of directors for the Musculoskeletal Oncology Research Initiative, which is a national consortium of centers that are aimed at trying to combine our efforts to study these rare diseases rather than just looking at single institution studies where we don't have a whole lot of these cases on our own. We do have a residency program that trains the next generation of orthopedic surgeons as well. And we just had our first resident ever going into orthopedic oncology graduate just last month. We have another resident coming up that will be going into orthopedic oncology as well. So we're hoping to continue to contribute on a regional and national and even international level in the management of sarcoma. So in terms of sarcoma, how do we treat it? Well, you can see by this sort of lattice work, it's incredibly complex. It requires a multidisciplinary panel of experts, and there's no real treatment algorithms like exists for some of the other more common carcinomas. Those ones are so well studied and we have such well-established treatment paradigms that often you can plug patients in where they're at with their cancer and where their level of treatment and go from there, and there's automatic treatments. When it comes to sarcoma, every one of these patients gets discussed at our multidisciplinary tumor board. So a lot of these different disciplines that are listed here take part in that discussion, and we essentially look at what available literature there is out there, as well as all of our own personal experiences with this particular tumor or this particular anatomical region that's being involved, and we come together and figure out what is going to be the best options going forward for this patient. So the ultimate goal is truly customized patient-centered care involving this multidisciplinary team of experts. So that brings in orthopedic oncology. So once we discuss all of that and we say, okay, surgery is going to play a role, where do I come in and what is orthopedic oncology? So orthopedic oncology is the surgical management of tumors of the trunk, buttocks, arms, and legs. These tumors involve bones, nerves, or any other soft tissues in these areas like muscle, fat, you name it. This can include both benign or malignant tumors. So the most common benign tumors that I treat are lipomas, which are benign fatty tumors, nerve sheath tumors, which involve the casing around nerves, or osteochondromas, which are these abnormal bony outgrowths that occur as a result of abnormal growth and development in our skeleton. So these are usually things that I see in either kids or young adults. The common malignancies that we treat are, as we just talked about, sarcomas, because they tend to show up in these anatomic regions and involve our connective tissues. Otherwise, metastatic carcinoma, lymphoma, or multiple myeloma, because these often involve the skeletal system. So as soon as these end up in the bones and in the extremities, we go after them from our perspective as well. Tumor-like conditions that we address are things that mimic tumors, meaning they can either present just like them, or the surgical management is very similar to tumor, which is cut it out and then rebuild it. And so the most common tumor-like conditions that we see are infections, immune system reactive processes, or hemangiomas, which are benign collections of an abnormal proliferation of blood vessels, but it's not an actual tumor per se. So orthopedic oncology really wasn't even around until the 1970s. And what changed and what brought that around was that chemotherapy started being used more and more often for sarcomas. And at that time, we were also at a changing point where joint replacements and bone replacements and things like that started to become available. So we now had means of not just amputating a tumor automatically whenever it showed up in the extremities. Instead, we could now save the limbs. And so because that became an option, a few guys started tailoring their practice towards that, and they started becoming the experts, and they started naming themselves orthopedic oncologists. And so these are the four guys that sort of started it all once upon a time. So back in the 1970s, this was it. Bill Enneking, who was at the University of Florida in Gainesville, Florida, Henry Mencken, who was at Harvard University in Boston, Michael Simon at the University of Chicago in Chicago, and Jeff Eckert at UCLA. So had you had a sarcoma on the West Coast, you'd be heading to UCLA right now if this was 1975. Thankfully, over the years, we've now peppered enough of us out into the community that most patients don't need to go more than maybe an hour or two to see one of us, with a few exceptions. Every now and then there's patients that live very far away, and Alaska is still an uncovered resource. So a lot of them have to still come back to the mainland United States to get treated. Currently, there's less than 150 active orthopedic oncologists in North America, and there's less than 250 worldwide. So there's not a ton of us out there because these things are rare. We tend to cluster in areas of larger population where there are more patients who will see us. So that's why the rural communities are still relatively disconnected from us, but we try to have resources available to make it easier for them to come to us. And one of the things we do here at Good Samaritan is the Pastega House. So I do have patients that come see me from Coos Bay, even from, you know, the California-Oregon border, way down south. And so a lot of times with the Pastega House, they can stay, their family can stay, we can get them taken care of up here, and they don't have to be far away from their support network. So what exactly is limb salvage surgery? That's what came out of the development of orthopedic oncology. So previous to the 1970s, if you showed up with a tumor in your extremities, you got an amputation very quickly, and that was pretty much all we had. The problem with that is, number one, obviously those are mutilating and very functionally changing procedures, but the other thing is that didn't really change survival much, and it's because what we find is most sarcomas are already metastatic at the time of diagnosis. And so again, in the 1970s, when we started using chemotherapy, we saw 5-year survival rates change from less than 10% to 75% with sarcoma. And that also allowed us to preserve the legs. And so now we're preserving the legs, not amputating. We're using chemotherapy sometimes, and we're getting better survival preserving the leg than we were with an amputation. But limb salvage surgery encompasses a whole slew of different things we can do. So the first thing is tumor removal alone. There are still times where the tumor shows up, it's the right kind of tumor in the right anatomical location, where all we have to do is cut out the tumor and nothing else. Sometimes we have to remove the tumor and then fix the bone. And so that's where we have something that's involving the bone. It may be benign, so we don't have to cut the bone out, but we have to take it out of there because it's structurally damaging the bone. So when we take it out, okay, we've solved the tumor problem, but we still haven't solved the structural problem of the bone. So then we maybe fill that cavity with cement, or we bone graft it, or we add a plate and screws, or a metal rod, or something like that. So that's all part of the limb salvage surgery. Other things are tumor removal with soft tissue reconstruction. So instead of the bone, maybe it's involving something meaningful in the soft tissue. So if we take out a muscle or a tendon that really means something to that patient's function, we use plastic surgery, muscle advancements, or even muscle transfers, sometimes even vascular bypass if a critical nerve or blood vessel has to be removed with the tumor to reconstruct that defect and preserve the limb without having to resect the entire tumor and the blood vessel, and now we can't save the arm anymore, so it has to come off. So now we're able to save these structures. Tumor removal alone with bone reconstruction or replacement can occur with something called an intercalary procedure. So all of our bones have a joint on one end and the other end, and then when tumors show up in the middle, what do? So now what we do is we can take that middle part of the bone out, preserve the joint at the top of the bottom, and do what we call an intercalary or interpositional, so basically in the middle procedure, where we can either reconstruct that defect with metal or with a big allograft of a bone that came from a donor, basically. The other flip side of that is tumor removal with artificial joint replacement. So now maybe it's not involving the middle of the bone, it's involving the end of the bone and either close or actually involving the joint itself. Well, now we can cut that tumor out and replace the joint and plug that back into the remaining healthy skeleton with stems, with cement, with screws, with whatever we need to do, but we can now preserve that limb again by just replacing the joint. Finally, it involves management of failures of these reconstructions with revision surgery. So some of these surgeries are very large with very high risks that come with them. And so if we see an infection or a fracture or a failure of that structurally or functionally, instead of, again, bailing out to an amputation, we can now fix some of those problems with some of our modern technologies that are available to us. So it may mean more surgery, but we can still do what we need to do to save that limb and preserve function in that extremity. So here I'm going to now go over some examples of what I mean by each of those. So tumor removal alone. So this was a case where it was a young woman, she was only about 25, and she had a chondrosarcoma, which is a very rare type of bone cancer in her pelvis. And if you can see my cursor, there's the tumor right there, and you can see it sort of damaging and eating through the bone where we've lost the calcium in some of these spots. And you can also see the hip joint right here, and that it's extremely close. Because chondrosarcoma typically does not respond to chemotherapy or radiation, it's really just a surgical disease. We cut it out with curative intent. And so with this particular case, historically, what we would have had to do is cut the pelvis right here and maybe amputate the entire leg or do a really complex reconstructive method to rebuild the hip. Now, what we can do, and what this is a screenshot of, is actually computer navigation using a CT scan of this actual patient and matching that up with what we're seeing during surgery with a probe. And we can now thread that needle and make a very narrow cut and preserve the hip while removing the tumor and making sure we get a good margin around the tumor, get that cancer out of there, but don't do a functionally mutilating surgery on the patient. And so this is on the bone to show where we need to cut right across this bone on each of these planes to make sure that we preserve the hip but remove the tumor in its entirety. And so that's all we needed to do. And so because of that, we don't need to rebuild anything. We don't need to do any additional procedures, and it's just the surgical removal of the tumor alone. The next thing is when we need to augment with fixation. So as I mentioned before, we've now addressed the tumor and the defect created by the tumor, but the bone is still weakened by the tumor, and so we need to structurally reinforce that. So this image on the left here is where we put a plate and screws and cement into the cavity of the tumor to act as both rebar for some of these screws, but also, and more importantly, just to fill that and give immediate structural integrity to the screws. So this is a patient that actually had a cancer in their bone with a fracture through it. You can see this step off in the bone right here. and that's what's created the defect and the structural problem. And so even going in here and removing that tumor, we still have a fracture in the bone. So we've got to fix that. We've got to structurally re-support the bone. This one here was a patient that had a very large soft tissue sarcoma in their thigh that was actually wrapping around the femur. And so in order to remove it but preserve the femur, we had to strip all the soft tissue from around the femur. And so that means that we compromise a lot of the blood supply to the femur, and we put it at risk for fracture. So we stabilize this femur with a big long rod that goes all the way down the middle of the femur. Even historically with that, when that technology was available, it was a giant metal rod. And the sarcomas, we need to follow these with MRIs after surgery in order to make sure that tumor is not coming back. With a big metal rod in there, the MRI gets clouded and we can't see very well. So this is actually a special kind of rod that's actually made out of carbon fiber that only has this tiny thin metal rod or metal wire going down it, so you know it's in there, and these tiny little things that show you where the holes in that are to add interlocking screws to help stabilize that rod in place. But now we can get a crystal clear MRI of this particular area. So this enabled us to save the leg, save the bone, and allow us to do appropriate surveillance afterwards without clouding the picture for us. Endoprosthetic reconstruction is the next big part of that that we had previously talked about. So what endo means is inside, prosthetic, so a prosthesis. So just like when someone gets an amputation and they get a prosthesis, that's an exoprosthesis, that's outside of their body. When we cut out bone and give them a replacement of that bone, that's an endoprosthesis. And so these come in many varieties. So replacement is the one we just talked about, where you remove a tumor in the middle of the bone, and then you jump that gap now with a big metal implant that anchors into the bone up and down, and you preserve the ankle joint below and the knee joint above in this patient's tibia. Joint replacement alone, so here's a hip replacement in a patient that had a tumor in the head of their femur. So we can remove that and do a conventional hip replacement. This looks and is the same stuff that we use when we do a hip replacement for arthritis. Then you can do what's called a mega endoprosthetic, which is replacement of more than just a simple joint. So now we're replacing joint and additional bone. So here is a total femur replacement. So we've replaced the knee joint at the bottom, the hip joint at the top, and the entire bone in the middle. So this is what's termed a mega endoprosthetic. So lots of replacement. And so now this new metal bone will serve as the anchoring point for muscles, and that's what these holes are to sew muscles down to their common attachment points to preserve them and preserve function and give artificial joints to the patient so that we don't have to amputate the entire leg. Then the other side of that is custom implants. So this is available off the shelf. But when you have a complex defect like this pelvis, for instance, when you cut this area out, we don't have off-the-shelf products to jump a gap that big and recreate a hip joint. So instead, we create a custom product by sending the patient CT or MRI to a company, and their engineers then look at that and say, okay, what kind of defect is going to be left behind, and how can we 3D print something to fill that defect that still gets fixation in what's left? So now we've been able to jump the gap, provide a hip replacement, and provide fixation into the remaining healthy bone with all these screws up top so that we can anchor it and we can have good long-term longevity of this and rebuild and preserve the patient's hip, leg, and function. Endoprosthetic reconstruction actually started in 1890 with a German surgeon named Themistocles Gluck. The first artificial joint replacement ever made was actually made out of ivory, and it was a wrist replacement, which is not something we commonly do today. But he also made the first artificial hip replacement out of ivory. So he really opened the door to begin all of this. Then we discovered metal hip replacements in the 1940s and metal knee replacements in the 1950s. So now we're able to do more joints, and we're now using metal and things like that that will last longer and be less brittle than ivory. Mega endoprosthetics came around much later. So these are the things that came around in the 70s that allowed us to finally begin orthopedic oncology as a true specialty. Again, we just discussed it's replacement of more than just a simple joint surface. It's bulk bone replacement. Initially, before that, all we had was cadaver bone transplants. So when someone would die, they would donate their organs. They would also donate their bones. And so we'd take their femur and put it inside someone. But in the 70s, we started getting metal. And so first, we started with ceramic endoprosthetics for replacement of the upper half of the humerus. And then in the 80s, the first metal total femur replacement was done. So now we have better things. However, even at that time, they needed to be custom made. So you had to measure the anticipated defect of the patient, send it to a company, and they would manufacture something of that specific length. Now, all of these things come modular in all these pieces and parts and off the shelf so that we can custom make them to each patient. So we can change the lengths of each of these components to rematch their anatomy, their leg length, all of that stuff. So again, at first only custom. But what was interesting about that is waiting on the manufacturing time for these custom things, 3 to 6 months back in the 70s and 80s, is the reason we discovered neoadjuvant chemotherapy for osteosarcoma. So now, for those particular patients, we use chemotherapy up front before surgical removal of their tumor, because we find that that actually improves their survival significantly by essentially jumping on that tumor and any of it that is spread already before you address the main tumor where it all started. As the indications expanded not only to tumors, but to complex revision joint reconstructions and staged infections for reconstructions, these became more commercially available. And so that's why now almost every implant manufacturer has their version of these modular mega endoprosthetics. So what are the complications of these? Well, you name it. Anything and everything can happen. There are medical complications because these surgeries are long. We disrupt a lot of anatomy. There's a lot of blood loss. They put a lot of stress on the body. And there are a lot of mechanical problems with these. They can break, they can fail, they can not work right, they can still give you a leg length discrepancy or give you poor joint range of motion or unnatural joint range of motion that doesn't feel good to you. So all of these things can happen. So the big crux of all of this is not only the patient-centered care with sarcoma, but informed consent, going over exactly what are the anatomic defects, how can we rebuild those, what are the appropriate expectations for function after that, and what are the realistic medical and mechanical problems that can arise as a result of a surgery of this magnitude coupled with the type of reconstruction that we're using. So what goes into this is the patient goals and expectations. What do they want out of this? What are they hoping for? What do they expect should happen? The age of the patient and the life expectancy of the patient. So the answer for an 8-year-old may be very different than a 50-year-old and very different further from a 90-year-old. The other thing is there is no algorithm with this. It really comes down to, we could have the exact same tumor in the exact same anatomic environment in 2 different patients and make 2 different completely choices on how we're going to manage that based on all of these specific things involved with the patient and based on their informed consent and what they're willing to risk and what they want to try. So in conclusion, orthopedic oncology is but a small part of the multidisciplinary care for these complicated cases here at Good Samaritan. Limb salvage surgery has now become the standard of care when anatomically possible for sarcoma in the extremities. I do still perform some amputations because sometimes too many vital structures are involved that they can't be saved and we can't save a viable extremity, but those types of situations are becoming more and more rare. Outcomes, local recurrence, and mortality are no different with limb salvage versus amputation for sarcoma now that we have these newer technologies available to us. Limb salvage surgery is a burgeoning area of clinical and technological advances with tons of options currently available, and we continue to expand these technologies. Each case must be tailored to the specific patient, anatomic considerations, stage of the tumor, tumor type, goals, informed consent, and the patient expectations, as well as family. So this comes down to a discussion with the patient and their support network as well. So for further reading on either Good Samaritan, on the Musculoskeletal Tumor Society that oversees sarcoma management and limb salvage, as well as these specific cancers, I found a couple of online resources here available to you. And as Carmen said earlier, if you want a copy of all this, we can certainly send that to you. Just reach out to her and email her, and we'll be happy to get those to you. But that's all I've got for you today. So I thank you very much for listening. And so I'm happy to entertain any questions you have about me, about Good Samaritan, about sarcoma, about orthopedic oncology, anything we can do to help you understand all of this.
Thank you, Dr. Tedesco. Right now, we are going to give participants time to enter their questions and comments in the questions menu. While participants are entering their questions, we'll go over some contact information and upcoming events. If you would like to obtain more information or resources about cancer, feel free to contact the Cancer Resource Center by phone, email, or visit our website. You can also email us if you want the slides. Right now, they are available to be downloaded from the GoToWebinar handouts menu. But if you have any trouble, feel free to send us an email. I will send you the slides. These are the events that we have coming up next week. We have skin cancer prevention, and on July 20th, decoding your mammogram. So all of you are invited. Please join us, and if you are interested, email us or call us, or if you receive our newsletter, you probably already know about these. So now let's go over any questions. So I just see comments thanking you, Dr. Tedesco, for your talk. I don't see any questions yet. Let me see. Nope, no questions. So last minute. All right, so I just see comments saying thank you, great presentation. So if there is any question or something comes up later, feel free to send us an email, and we will make sure that Dr. Tedesco gets your question, and so you can get your answer. Please, once we finish the presentation, fill in the survey that will open right after the webinar has concluded. It will help us plan for future presentations, and it'll help us do our work better and offer better resources for you. Thanks to Dr. Tedesco for sharing his time and knowledge with us. Thank you so much. And finally, thanks to all of you for participating today, and have a wonderful